Thank you for joining us today. I'm Dr. Harold Burstein from the Breast Oncology Program at Dana-Farber Cancer Institute and Harvard Medical School. And this is an expert perspectives on the use of CDK4/6 inhibitors in the management of ER-positive metastatic breast cancer. Very fortunate today to be joined by two good friends and two of the world's experts in the use of this class of drugs, Dr. Nick Turner from Royal Marsden Hospital in London and Dr. Maura Dickler from Memorial Sloan Kettering Cancer Center in New York. Thank you both so much for being here. Nick, you've been involved in both some of the preclinical work and some of the pivotal trials of these drugs. Tell us what has happened so far in the development of palbociclib for ER-positive metastatic breast cancer. Let's talk about first-line therapy initially.
So the key studies that have reported out with palbociclib were first for the Paloma 1 study. This was in patients who are mostly presenting first line with ER-positive HER2-negative breast cancer and had either had no endocrine therapy before, or if they'd had aromatase inhibitors, they'd had a gap from their adjuvant therapy. And in combination with letrozole and palbociclib, doubled progression-free survival compared to letrozole alone.
And so that led to a rapid FDA accelerated approval for the combination in first-line treatment. And now what we're learning this week is that there's been a large confirmatory trial, the so-called Paloma 2 trial. What's the design of that and how did it differ and what were the major results from that?
So Paloma 2 is over 600 patients. It is a confirmatory trial of Paloma 1, so it's in exactly the same population. So first line, either endocrine naive, they've never had endocrine therapy before, or at least 12 months after stopping their adjuvant AI. And it was a randomization 2-to-1 between letrozole and palbociclib and letrozole and placebo.
So what were the major findings from that trial and how do they compare to the Paloma 1 study?
Well, the major findings of this study were really remarkably similar to the Paloma 1 trial for the confirmatory study. So the control arm of letrozole with placebo was 14 months, going up to 24 months, in fact just over 2 years for the combination of letrozole.
So nearly doubling the time of tumor control.
Nearly doubling the duration of tumor control.
That's really quite unusual, I mean, in the sense that we often see when you do a exciting randomized phase 2 and then enlarge into a phase 3 that there's a regression to the mean, that you see less dramatic results in the phase 3, but it doesn't sound like that was the case here.
Well, you know, the control arm did a little bit better than was seen in the phase 2, but I think the impressive thing is that actually the combination arm with palbociclib also did better, going over 24 months.
So we've learned a lot about the toxicity of palbociclib along the way. What are some of the major adverse events that you see, and what do you tell patients when you're talking about starting the drug?
Well, neutropenia is very frequent. So bone marrow suppression, most commonly with neutropenia, is very common. Over half of patients get grade 3 or 4 neutropenia, but this is asymptomatic. For most patients, that doesn't translate to really any problem at all. There's essentially no increase in febrile neutropenia. With the exception of the bone marrow suppression, in general, palbociclib is really remarkably well tolerated. There is a low level of fatigue, a small amount of alopecia, and some patients get some stomatitis or diarrhea, but in general, palbociclib is very well tolerated.
Maura, you've had experience with this drug in clinical trials as well as some of the other CDK4/6 inhibitors which are in development. Just pick up on that briefly. What do you counsel a woman to expect when she's starting one of these CDK4/6 inhibitors in the way of side effects, and how would you contrast that with either endocrine therapy alone or chemotherapy?
Well, typically, for a woman who takes letrozole alone, she may have some joint pain and sometimes some hair thinning. When we add a drug like palbociclib, I've noticed that many more women have hair thinning, never complete hair loss, but it's something that they definitely notice that's of bother to them.
Yeah.
The other side effect is the neutropenia. It now requires counts to be checked every other week for the first 2 months, and that's very different than what we were typically doing for endocrine therapy alone, where patients really didn't need to be seen sometimes for every 12 weeks in clinic once they were stable on it. Here we really do need to monitor them more closely, especially in the first 2 months.
So if they have a neutrophil count that's sort of between 500 and 1,000 in one of those blood tests at either 2 weeks, 4 weeks, or 6 weeks, what do you actually do? Do you hold the drug or do you lower the dose right right away?
I initially hold the drug, and I'll hold it for a week and see how they recover. And I find many women do fully recover, and then I resume at the same dose. I don't immediately do a dose reduction.
And do people tend to tolerate that? Or in my experience, it's about half the patients you can get away with that higher dose at that point, and about half you end up reducing the dose.
Yeah, I would agree. I think that if they come back a week later and it's low again, that I would hold again, and then when I would reinstitute, I would reinstitute at the next lower dose. So if it was 125 milligrams, I would reinstitute at 100 milligrams.
Great. So Nick, we've seen very impressive data for first-line therapy with palbociclib. We're talking about now 2 years of tumor control, which is truly longer than anything I've ever seen with endocrine therapy historically. There are also data for treating more refractory patients, the so-called Paloma 3 trial. What was the schema for that study, and what were the major findings?
Yeah, so Paloma 3 was for patients who had progressed on their prior endocrine therapy. Paloma 3 also included premenopausal women, so that was one of the other major differences about Paloma 3.
So they had ovarian suppression at the beginning.
Yeah, exactly.
Yeah.
So following really the NCCN guidelines, all patients who were premenopausal had to be on gazerolin to render them biochemically postmenopausal,
Right.
if you like. And the schema of the Paloma 3 study was a backbone of fulvestrant.
The
this time,
selective estrogen receptor degrader.
yeah, thank you. So the fulvestrant with or without palbociclib. And this again demonstrated really pretty impressive activity for palbociclib, going from 3.8 months on the placebo up to 9.2 months. So over doubling the duration of disease control, improving progression-free survival by 5 months.
Anything really different about the side effect experience with the aromatase inhibitor versus fulvestrant?
No, really, actually the side effect profiles across all 3 studies, all of the 3 large studies with palbociclib have been really very consistent.
Now, you've had the opportunity to look at a lot of biochemical markers that might figure out which tumors are selectively likely to benefit. Has anything emerged as a particular predictor, whether it's ER, cyclins themselves, estrogen receptor mutations, things like that?
Yeah, as you say, we've looked at a lot of things so far. We've looked at amplification of cyclin-D1, the key protein that activates CDK4. We've looked at estrogen receptor expressions. We've looked at the common mutations. At the moment, none of those have identified a sensitive subgroup. So the only marker we've got at the moment is estrogen receptor positivity and HER2 negative. One of the reasons for this is that CDK4/6 is key to the biology of this subtype of breast cancer.
These ER-positive tumors are really driven by normal cell cycle physiology.
Yeah, exactly. So it's hard to identify markers of sensitivity. I think the work will come from trying to identify those patients that are refractory to these drugs, and can we identify them up front?
Maura, you've had a lot of work with a related product, abemaciclib, which is a same class of drugs, but has some differences between palbociclib. What are some of the biochemical differences between abemaciclib and palbociclib?
Well, abemaciclib has more potent inhibition of CDK4 than CDK6, and therefore abemaciclib likely has less impact on the bone marrow, less myelosuppression.
Less neutropenia.
Correct, yeah. So abemaciclib, however, has more diarrhea, and so it may be that differential potency that impacts the different side effects of the drug.
So here at ASCO in 2016, you presented a major phase 2 experience with abemaciclib. What were the patient population for that trial, and what were the major findings?
So this trial was really very different from the Paloma studies in that this really was looking at the activity of single-agent abemaciclib in a more heavily pretreated patient population. All of these patients had to have had prior endocrine therapy, and as a matter of fact, they were no longer suitable for another line of endocrine therapy. And they also needed to have chemotherapy in the metastatic setting, at least one regimen, and they were allowed to have up to 2 prior chemotherapy regimens for metastatic disease.
So that's a group of patients, as you said, that really looks very different from first or second line endocrine therapy. They've all had chemo, and they've been reasonably resistant to endocrine treatments.
Correct. Really, their next standard of care would be chemotherapy.
And was the drug given with endocrine therapy again, or was it a single-agent trial?
This was a single-agent study. This study was really designed to confirm the phase 1 experience with abemaciclib. In a phase 1 trial, there was a cohort of patients with ER-positive, HER2-negative breast cancer, and they had a single-agent response rate of about 26%.
So that's pretty high compared to what, I mean, that's putting you into the realm of really what third-line chemotherapy might historically accomplish. And the tolerability profile for abemaciclib, we mentioned the diarrhea, a little bit less in the way of neutropenia. Other things to distinguish it from palbociclib?
Well, there seems to be more fatigue with abemaciclib as well. So decreased appetite, nausea, but really the main ones are the diarrhea and the fatigue.
So it's actually a pretty exciting time in ER-positive metastatic disease with a lot of trials going on. What are the next kind of major studies to come through? What are we waiting for to sort of figure out where these drugs really belong in our regular armamentarium? What's next out for abemaciclib?
So there are 2 randomized phase 3 studies of abemaciclib. There's the Monarch 2 trial, which is looking at a fulvestrant backbone with or without abema.
So very similar to Paloma 3, I suppose.
Correct. And then there's Monarch 3, which is the aromatase inhibitor study. It allows letrozole or anastrozole with or without abemaciclib.
Can I just ask, why can't they number these all so that they are parallel structures? It would make it so much easier to remember the whole thing. Nick, we also saw recently a press release looking at the so-called Falcon study, which sort of brought another wrinkle to it. I don't know the data, but it said that first-line fulvestrant might be a little better than first-line aromatase inhibitor therapy. Is that something that you've been anticipating, or what do we know about those choices in the management of ER-positive metastatic disease?
Well, we've had the first study, which was the phase 2 study that compared anastrozole and fulvestrant. And that identified in that population that fulvestrant was superior to anastrozole in first-line endocrine-naive patients. So we now know, but we haven't seen the data yet, that Falcon has confirmed that fulvestrant is better than first-line anastrozole. But really the question we're waiting to see is how much better? Yeah. And will it need to begin to change how we think about the endocrine backbone for all of these studies? And of course, the other study we're waiting for as well is of the ribociclib studies. The ribociclib, the Mona Lisa studies are also due to
randomized
report
trials in the same kind of AI plus minus ribociclib or fulvestrant plus minus ribociclib mode. What do you think in a few years, are these going to be pretty standard drugs? Are we going to have multiple agents in the marketplace? What is your expectation more?
I think so. I do. There are trials now looking at palbociclib in the adjuvant setting. And although that's a large trial and will take many years to report, I think looking towards the future, if we'll be using these agents even earlier, that will then impact our use in the metastatic setting.
So let me wrap up just by asking you about a couple of common clinical scenarios and get your thoughts on what you might actually do. A woman who's been on an aromatase inhibitor in the adjuvant setting, she's 4 or 5 years out from diagnosis. She now develops multiple areas of bone metastases. What's your treatment of choice at this point? Is it fulvestrant? Is it fulvestrant and palbociclib? Is it chemotherapy? Nick, what would you think of in a patient like that?
So this is a patient who's relapsing on
an
their
aromatase inhibitor.
So I think the key question we have in deciding how to treat these women is whether they're relapsing on their aromatase inhibitor or they've got a gap. So for those patients who are relapsing on their aromatase inhibitor, we're now into the Paloma 3 territory. So there's no data for just adding the CDK4/6 inhibitor and continuing the aromatase inhibitor. All the data suggests that we should look at changing the endocrine backbone to fulvestrant and then adding in a CDK4/6 inhibitor on top of that.
Got it. And Maura, let me ask you about a variant on this. So let's take a woman who had finished an AI or tamoxifen many years ago, now presents with relatively isolated and somewhat minimal metastatic disease, maybe an enlarged lymph node or maybe an isolated bone metastasis. Are you going right away for a combination of an AI with the palbociclib, or are you still thinking about an AI by itself in those patients?
No, I definitely think that there's a subset of women that can be treated with an AI alone. And I consider their age, their comorbid medical problems, issues about quality of life. And there are patients that I think can really benefit from letrozole alone, and that patient might be one of those.
Well, I want to thank you both for joining us today. This has been a great discussion, and what really amazes me is that 40 or 50 years into the modern era of management of ER-positive metastatic disease, we're seeing new pathways, we're seeing multiple new drugs come along, we have exciting correlative science work to support it, and it feels kind of fresh again in a way that perhaps things hadn't for quite some time. So thank you for joining us as well. I'm Harold Burstein from Dana-Farber Cancer Institute. I've been joined by Nick Turner from the Royal Marsden Hospital in London and Maura Dickler from Memorial Sloan Kettering Cancer Center in New York. This has been an expert perspectives on the use of CDK4/6 inhibitors in the management of ER-positive metastatic breast cancer. Thank you very much.